Welcome to the webinar. Welcome to CAMHS Campfire. It's really great to have such a big audience. We're really excited about this session on predicting complex PTSD in foster care. We have got a brilliant panel. I always say that, but today we really have got a brilliant panel. We've got Rachel, Dr. Rachel Hiller, a clinical research psychologist based at the University of Bath. And Rachel's work focuses on childhood trauma and mental health and support, especially in young children and children in care. Welcome, Rachel. We also have Helen. Helen is a professor of child and adolescent psychiatry at the University of Glasgow, Professor Helen Minnis, and her work focuses on attachment disorder, the clinical aspects, assessment tools, behavioural genetics, and she's currently involved in an RCT of an infant mental health service for young children in foster care. And we have Aisha, who is a campaigns advisor. Hi Aisha, thanks for joining us, lovely to see you. Campaigns advisor with NIAS, that's the National Youth Advocacy Service. And Aisha has lived experience of being in foster care. So brilliant panel, I'm sure you'll agree. And I'm going to ask them all to introduce themselves and to answer some questions in a second. But before we do, we want to find out a bit about who we've got in the webinar. So we've got a panel, a poll rather. So please just tell us which of these best matches you and your involvement in this webinar. I hope that there's a category there that fits who you are. There's an other at the bottom if there isn't. It's really helpful for us to get a sense of who we've got here. And thanks to everyone for saying hello in the chat. Do please carry on doing that if you haven't so far. Introduce yourself. And if you're talking in the chat, please remember to choose the panelists and attendees drop down so what you post can be seen by everybody. So hopefully we'll have a result for this poll in a second. Okay, wow, what a mix. That's great. So it looks like the biggest group is other. So that's nice. We've got a nice mix. We've got a fair few clinical psychologists, but also some other clinicians, researchers, CAMHS practitioners, people from social care, from schools, lots of students, trainees, researchers. That's great. Really nice. Thanks for joining us, everyone. So we will try and keep the conversation flowing. If you've got questions or comments, please do post them in the chat or in the Q&A. And as always with these campfires, we try and do three things. We try and kind of talk about the subject broadly and introduce you to the subject. And so we're going to do that in a second. Then we're going to look at a piece of research. So Rachel published a paper fairly recently, and we're going to look at that paper in a bit of detail. And we're going to critically appraise it, and Douglas is going to talk a bit about that. So I should say people in my team who I'm working with alongside Matt, we've got my colleague Douglas Badenoch, who's an information scientist and fellow ELF, who's going to be talking in a minute. And we've also got Dr. Steph Lewis, who's a clinical lecturer in child and adolescent psychiatry. And she also has a special interest in childhood trauma and mental health. Steph is going to be on the chat this evening, so you may well see comments from her fairly soon. And then at the end of the webinar, we're going to try and think, so what? Now that we've looked at this research, now that we've discussed this subject, what are we going to do about it? What impact should this research and this conversation have on our practice or on future research? So hopefully we can make the next hour or so really relevant and really interesting for you all. I'm going to start off by asking Rachel, before we look at your paper, Rachel, just tell us why foster care and PTSD is an important conversation to be having in the first place.
Yeah, I'm trying not to get distracted by the chat and everyone introducing themselves, but it's so lovely. And I saw also there's some foster carers on the call too, and there wasn't an option for you, but I wanted to say welcome. I'm so pleased to have foster carers on the call here and hear what you think about this research. So, well, in terms of why I think PTSD is important in this group, it is just fundamentally because unfortunately, we know that young people that enter our care system have often experienced various types of trauma, and in a very kind of simple, not to simplify it too much, but PTSD, post-traumatic stress disorder, is a trauma-specific mental health outcome. So when we've got a group that we know have all experienced trauma, and not necessarily, you know, often that has happened before they come into care. We know, for example, that adolescents are our fastest growing age group coming into care at the moment. So often these experiences have happened over many years. Sometimes those experiences can happen whilst they're in care as well. So PTSD is a mental health difficulty that we think should be routinely screened in this group, but also I think really importantly is that we have treatments for it. So it's not a diagnosis that has to go nowhere. If a young person has PTSD, we have treatments available to help them overcome that.
And can you just give us a bit of a definition, Rachel, particularly for those of us who aren't that familiar with PTSD, what the difference is between PTSD and complex PTSD, which is, I guess, what the focus is of the paper and the discussion this evening?
Yeah, so the paper looks at both predictors of PTSD and predictors of the complex features of a new diagnosis called complex PTSD. And the language is, I mean, I hope we'll talk about this a bit later, because I think there's pros and cons to all this different language that flies around here. Lots of people talk about developmental trauma, for example, but PTSD is a mental health difficulty that is defined in our diagnostic manuals. And the cluster of symptoms include re-experiencing symptoms, and that's things like nightmares or intrusive memories or flashbacks. So having memories of what happened really pop into your head when you don't expect it, and feeling like you're in danger again, for example. Another core symptom is avoidance, so avoiding talking about it, avoiding thinking about it, avoiding places that might remind you of what happened. And then we have hyperarousal, which is probably the symptom most easy to see if you're a carer, for example. And that's things like being very jumpy, very easily startled, also difficulty sleeping, difficulty concentrating, those kinds of things. And then finally, we have negative cognitions and mood, like low mood, for example. So in 2018, one of our diagnostic manuals introduced a category called complex PTSD. And that was really introduced because I guess there was a lot of discussion academically, but also clinically, that when people had gone through more complex trauma, like child maltreatment, for example, like abuse or neglect, their symptom presentation maybe wasn't adequately covered just by PTSD. But what I think is really important to know about complex PTSD is that fundamentally it's still PTSD. And I think, as you know, clinicians and even academics as well, we really need to hold on to that. So if you've got complex PTSD, you still meet criteria for PTSD. So the treatment pathways are the same at the moment. Maybe, you know, I'm sure there'll be a lot of research on this over the next few years. But the complex features are what's called interpersonal difficulties, relationship difficulties, emotion dysregulation. So, for example, when you get angry, taking a long time to calm back down, and then negative self-concept, which might be things like, I don't feel like I'm worth anything. So that's the cluster of complex features that come under this umbrella of complex PTSD. Great,
thank you. That's really helpful. Okay, brilliant. So Aisha, it's time to welcome Aisha to our event. It's really lovely to have you here. Thanks so much for joining us. I know you're a bit nervous. I'm a bit nervous as well. I always get nervous when I have to talk in these sorts of things. It's weird, isn't it? But it's a lovely place we've got here with some lovely people. So please feel calm and safe. I wanted to just start by asking you to tell us what you think of this topic. You know, why is this an important topic?
When I first read the research, I thought it was so eye-opening, even for me, just personally.
Oh, I think you've accidentally muted.
Sorry. Finding out that young people in care are 12 times more likely to develop PTSD was quite shocking. And I think it's important for a study like this to be out there and open to young people and those working with these young people, because a lot of the time, we don't understand where these triggers and symptoms come from. And it's very good to associate the cause to the effect, and I think, one of the symptoms that Rachel mentions are unhelpful thoughts. And that is something that happens a lot, where young people blame themselves and they start developing these false ideas and false realities of why they're going through, symptoms that could be treated and could be supported by the right people and through the right way. And I think it's very important that those working with young people are able to understand that it isn't just, a young person that is reacting or that has anger problems or that is suffering from, anxiety, because I feel like a lot of the time there are misdiagnoses involved when dealing with trauma experienced young people. So I thought it was very eye-opening, and it definitely helps in understanding what you are going through as a young person coming from that background.
Thank you. That's great. I'm going to come on to Helen now and just get a bit more background for us. Helen Minnis, she's a psychiatrist and a researcher. So from that background, Helen, tell us why you have especially been drawn to working in this field.
That's such a good question. I think, I ended up in some ways working in this field because I had a travel bug, and I ended up working in an orphanage in Guatemala, and I met lots of people who had very difficult early experiences. And I suppose I was always interested in why young people who've had these kind of experiences often struggle so hard to actually get help. And for me, I think PTSD is a particularly interesting thing to focus on when it comes to young people in the care system, because of that symptom that Rachel was talking about, which is avoidance. Because, for me, it's a bit like if you've got a sensitive tooth and, it's going to get worse if you drink something cold or if you go out in the cold. The last thing you want to do is to actually set it off. And the thing about PTSD, I think, is that the last thing you want is to think about those thoughts. But of course, that's what you need to do if you're going to get help. And that's why I think it's incredibly important that the work that Rachel's done, just trying to understand whether this PTSD is like all PTSD and should be treated the same way, because, many young people just don't even want to think about it, and so they need confident support. So that's why I think this is just such an important area to focus on, really.
And I've noticed, working on the mental health, in the last kind of 5 years or so, there's been a real shift in who within the mental health field, I'm thinking about all the different people who work in mental health, who is genuinely interested in adverse childhood experiences and trauma. It used to be quite a small, silo of people that were interested in that. But now it's literally everyone, because we're kind of recognizing as a society the links between early life experiences and trauma and mental illness, which are obviously, fairly obvious fundamental things, but it seems to be that that's really become a part of our sort of general social understanding. Do you think that's true, or am I in a bubble that is unrealistically naive?
I think that's very true, and I think it's got positive and negative sides, because, I think the most important thing to realise is that children and young people who are in the care system are as different from one another as are children and young people who are not in the care system. And they're as likely to have the same range of problems. They're probably at higher risk because of having had more difficult experiences. But, I think you just got to be so careful that this idea of trauma isn't a blunt instrument. We really need to be very, very critical about it and think carefully. And that's why I was just so delighted to see the work that Rachel and her team have done, because it takes such a critical look at this.
Do you want to come in, Aisha? Did you have something to add?
Yeah, I just wanted to say I definitely agree with Helen in terms of although avoidance is one of the biggest things, and I think having a study like this open to young people and those who are working with young people really help young people understand the reason why it is to face their demons, and to, you know, and by understanding where it's coming from, it's going to create this open bracket of conversation, talking about their trauma, talking about their feelings, and hopefully those working with these young people can support them in getting the right support. I think one thing that was very important that she mentioned is that young people in care are no different to other young people. You know, yes, they may have had traumatic experiences, but a lot of the times professionals fit them into this bracket of, oh, you are so special, what you have is ridiculously traumatic and you're going through so much. And they make the trauma, it's sad to say, exaggerated in the terms where it makes young people scared to even speak about their experiences. It makes them feel like, oh my gosh, am I the only person that's been through this? And when, to be honest, like the results kind of show, it's more the meaning of the trauma that affects the young person. And I think that's why it's very important to take an individualistic approach, as you would with any other young person.
Thank you. Rachel, just say something for a couple of minutes just to round off this introductory bit for us.
Oh, I mean, I feel like Helen and Aisha have just summarised that so lovely that not more needs to be said. But the one thing that I think we're all consistently saying, and it also leads to as well, which we might come back to later, is it's also not always that I love that Helen said that young people in care are as different between each other as all young people, and you know, I wish we would more have language where we think of them as young people first, and the fact that they're in care, I don't want to minimize that, because of course that's important, but it shouldn't be a blanket reason for decision making. And part of that in a trauma and adversity context as well is also kind of linking to what you were saying, Aisha, is not always presuming that you know what trauma it is that might be leading to their mental health difficulties. That just because you think something was really bad and it may objectively be bad doesn't mean that's what's on the young person's mind and what needs addressing. So I think what we're all trying to say is let's go into this with a bit more of an open mind and thinking about what the young people need.
Fabulous, thank you. All right, so we've got a brilliant conversation going on in the chat as always. Please do join in with that and contribute to that, and that's fabulous and that's ongoing. It's time for the sciencey bit now. So here comes Douglas, and he's got some slides and some sciencey stuff to say about Rachel's research. So we're going to teach you some stuff here about research and methods, and why this is an interesting paper, but also why it's what its strengths and limitations are. And then we're going to talk a bit later on about what we're going to do as a result of this research existing. So yeah, Douglas, over to you.
Thank you, Andre, and thank you, panelists, for a brilliant introduction. And thank you to the participants you're already posting really interesting comments and questions, which I've been trying to read. Some about methods and some about the context. And it seems like there's a lot of folk who are coming up against this issues in so many different contexts, sectors, you know, education, justice system and care. I think that underlines the task at hand to try and improve all of our understanding of what's going on here. Matt, would you mind throwing up slide number 1, please? Thanks very much. So when I sit down to critically appraise any paper, I guess there are 3 things that I'm looking for. First of all, what's the question that is being addressed by this study? Secondly, are the methods valid? And thirdly, are the results important? That's kind of, you know, my sort of 3-step boiling the whole process down. And that's the process I applied to this study. If you want to jump into presentation mode, Matt. I'm getting the slide deck here, and then jump back to slide two once you've done that. Now, with this cohort study, there's some challenges, and I don't pretend to pick up all the nuances here, but what I've tried to do is to pick up the broad brush issues that arise from cohort studies, where I guess we've done two things in this study. We've captured people at a moment in time and looked at an array of data about their trauma symptoms, their PTSD symptoms, and their trauma experience, and then followed up 12 months later to find out whether they've changed and what the relationships are between all those data points. So I tried to boil this down into one research question, which and other research questions may be formulated. But I broadly see this as being focusing on young people in mostly foster care, but they're out of home care. What is the relationship between the cognitive processes that they experience, their PTSD symptoms, and their complex PTSD symptoms? So the researchers are trying to look at how we understand it as well as what the symptoms actually are. So that kind of makes it a complicated study to read. But let's skip on. So with that in mind, we looked at what the researchers did. So we got participants from 3 local authorities in England. And for the participants who agreed to take part, the researchers looked at their history of trauma and their experience of maltreatment. They looked at their PTSD symptoms, including complex PTSD elements, and they assessed the sort of 3 main domains of cognitive process that underpin the psychological theories here. And those, we've already heard some quite good examples of those, talking about memories and how memories affect you. What are the coping strategies that people employ to be able to deal with their trauma, and the maladaptive appraisal. So there's some cognitive processes that people go through which end up with them making inaccurate assessments or overly negative assessments of what's going on. So this for me is one of the most interesting aspects of this study, is looking at these processes and how they correlate with the symptoms. And as we can see, the groups were followed up after a year. So we've got a kind of basic idea of what the study was about. Thank you, Matt. Delving into the details in a bit more detail, what I did was I pulled out the Casp critical appraisal checklist for a cohort study and ran through the questions looking for answers to these sort of checklist items. And as you can see, it's mostly greens, which was always reassuring. But there are some important limitations and some issues that I think it might be worth talking about, with hearing from the research team about. The first question I had was about how the sample was recruited. We've heard that about half the participants who were eligible to participate declined for one reason or another. So we'll maybe hear a little bit more about that in a minute. The other thing I think always with an observational study, you have in the back of the mind, you can't eliminate all the possible factors. You can't identify all possible factors. So there could be confounding things that affect the relationships that we find that we haven't thought about. It can be difficult to prove the directionality of causation. And that's the kind of issue that's important with this sort of condition, I feel, in that, you know, one's experience of the symptoms affects how one thinks about them, and so that relationship, I think, is something we'll maybe hear a little bit more about later on as well. And the last point I think would be worth talking about is the applicability of the results. This is question 10, and I noticed one of the comments in the sidebar. Someone was saying that we excluded people with existing developmental difficulties from the study. So that's the sort of thing that makes you think, well, does this apply to my population, or what section of my population? So that's the kind of discussion I think we can go on to have. But one thing I would say before we skip on is critical appraisal studies isn't about just picking holes. It's about identifying strengths and perhaps limitations. And I think what we can see is that, you know, particularly with, you know, if we're giving a lot of measurement tools and batteries of interviews and questionnaires with people, you know, that might affect how the response we get, the amount of data we get, and the quality of data we get. So I wonder if is it worth pausing just to pass over to Rachel. I wondered if you would mind just talking a little bit more about the sampling and recruitment, and just take us through how that worked, so we can get a bit of a broader picture than what we could get in the paper.
Yeah, so I think one of the really tricky things to balance with research like this, as it is with research with whenever you're researching humans, but particularly when you're researching with young people, and not just a broad population of young people, but young people that are used to professionals coming and going and making them do forms and not knowing what the forms are for, and you know, are very savvy to the way adults can be, to be perfectly honest. You've got to balance basically just feasibility considerations. So for the confounds, I think are really important, and the inclusion and exclusion criteria are really important. We didn't exclude all young people with developmental disabilities, but what we essentially said, and we also didn't assess young people for developmental disabilities, and we also didn't assess like IQ, for example, because we just didn't have capacity within the study to be doing that. That takes a substantial amount more time, but it's certainly worth considering. What young people were excluded from the study was if an intellectual disability or a developmental disability was at a severity where they struggled to manage a mainstream curriculum, which is an incredibly crude marker, obviously. I would absolutely say that, but that is fundamentally because it's a questionnaire study, so they're having to sit there and go through quite in-depth questionnaires, and you know, that's absolutely a limitation. In terms of how we recruited these young people, because that in itself was quite a process, because our local authorities were actually really amazing to coming on board with this, because when you first go out to a local authority and you say to them, I want to ask your young people how they feel about their trauma, you might imagine that the initial response is absolutely not. So it took a lot of trust and a lot of working together on why we wanted to do this research, and talking to young people about what they felt about this research. So we really try to co-develop our work with care experienced young people when we're putting together these projects. So we had 3 local authorities that were involved in this. The main places we worked with were Bristol and Swindon local authorities, who had some really wonderful people that really championed this research. And essentially we went to their teams and tried our best to consent in a systematic way, where we went team by team and got all of their eligible young people consented for the study. And we did that because what you want to avoid in studies like this is only getting sent young people that are doing really well, so we don't mind if you ask them about their mental health, or only getting young people that are doing really poorly because they're going to be doing symptom screeners and you might be able to tell us something about their mental health, because both of those extremes and difficult to manage, and also not necessarily appropriate in a research context. So we were really lucky that the services came on board and let us do more systematic recruitment. But ultimately, young people decide whether they want to be in studies or not, which means we always have selection bias as a limitation in our work. That's an unavoidable part of this kind of research, because young people have to decline participation. And if I had 100% of young people saying yes, they want to do the study, you'd be feeling pretty concerned about what was going on behind the scenes, because it's not a natural trajectory for studies. Douglas, did you have any specific questions about that I haven't, that you want me to cover? Or I can't keep track of the chat, sorry. But if
no, that's fine. Yeah, I've been trying to keep an eye on it myself, so I'm sure that was a brilliant answer. Thank you. I think that was really helpful, and it underlines that this is obviously one of the challenges in doing research in this area, is that it's hard to do research in this area.
Yeah, and I guess what the social workers and local authority managers really had to come on board with, which they were wonderful about, because it's a different way of working when you're doing research projects, but is that we want young people to be ultimately deciding whether they want to be in research or not. If they want their voice heard in research, we want them to have that opportunity. So we just don't want at a professional level to be presuming kids don't want to be in it, or blocking them because we've decided that they can't talk about their mental health, when actually maybe that would be something they would like to do. And our local authorities, I must say, were really wonderful in allowing us to do that. Mm.
Well, I'm sure that was a lot down to the hard work that you put in establishing those relationships. And I think, and just to kind of underline that discussion before we move on, I think the other thing to say that old EBM gurus used to say to me that you're unlikely to find a paper that's got exactly the population that you're, as it's exactly the same as the person in front of you. And so, and because this is such an individual thing, it might be more appropriate to ask, is this so different that the result, how different would people have to be that this study can't help us? So, and I think taking that kind of more positive twist on it is appropriate here for those reasons. Matt, could you please jump on jump back to the slides for me?
Right.
I've got a summary slide of the some of the points that the next slide after, yeah, this one, thank you. There's a slide there just summarizing some of the points I've raised so far. A lot of these points we've acknowledged in the published study. And one of the things we discussed in our pre-meeting was that the follow-up rate was very high by the usual standards of this kind of research, and that's something we can pick up later if we've got time. But an important point here is this last one, that this study is broadly consistent with what we would expect and from similar studies. So there's nothing to kind of necessarily frightening about these findings. Could you jump on, please, one slide, Matt? So if we feel that we're fairly happy with the methods, when we look at the findings of the paper, there's a lot of information that we could go through, and this is one of it's both the benefit and the harm, if you like, of doing these sort of regression analyses. We've got a lot of variables that we're correlating with one another. But one of the key findings that certainly struck me was the strength of the association between these cognitive processes and the symptoms, both of PTSD and the complex PTSD symptoms. There was also a strong correlation between PTSD and complex PTSD, but it seems like this suggests to me there's a lot of potential for what we can do with these folk by targeting the cognitive processes that we already have treatments for. So I just wanted to pause at that point. That seems to be the important time to come back to the group. And I wonder if you could start us off, Helen, just by thinking about those findings. We'll give you a moment to see you were tracking the comments there, doing sterling work. What's your take on the key take-home finding from the paper?
Yeah, I mean, even before getting into that, Douglas, I just wanted to say, I have done research with looked after accommodated young people, and I just want to say the number of hoops that you need to jump through to make sure that you're doing it properly is enormous. And to see an 80% retention rate just shows that Rachel and our team did this really well. I mean, I just wanted to applaud because it's such well conducted research, and it's really, really tricky to do really good research. But so for me, what I thought was really important about this study was that, you know, the big question, as you so beautifully described, Douglas, was that, you know, it was about mechanisms. Are the mechanisms for this group of children and young people the same as they would be for the wider population of children and young people with PTSD? And I think that really the resounding answer was yes. And that's really good news, because it means we don't have to reinvent things for this group of young people. It means we've got good evidence-based treatments, there are nice guidelines. And so, you know, it was back to that thing I was saying at the beginning, where as a clinician, we want to be able to offer confident support. So I think from that point of view, this paper is really important, because it really suggests that, you know, if a young person in the care system has PTSD, get treatment for PTSD, and it doesn't have to have whistles and bells. There's also lots of questions in the chat about other neurodevelopmental problems, learning disabilities. And, you know, what I think was a really important point made by Rachel and her colleagues in the paper was that this is a group where there are often overlapping problems. And so you made that point. But if you had tried to look at all of these problems in one paper, we would have ended up confused. So it was really helpful to have this very clear focus on PTSD, partly because it's so often missed. And I think for me, this paper gives me confidence as a clinician that why should this be any different if the young person has a different ethnicity than most of the kids in this sample, or has a learning disability? If it's PTSD, it's PTSD.
Yeah, that's a brilliant point. I mean, I think that was my feeling about it, was that it looks like there's targets to treat whatever we call it, and whatever the interactions might be going on. There's maybe the issue is not so much how you define them and categorize them as making sure you identify people who can benefit from. There's obviously, I mean, again, looking at the chat, there's obviously a lot of unrecognized difficulties going on. And does this mean that we just, what we need to be doing is identifying who can benefit from those treatments better?
I think one of the worries that we've been discussing about the term complex PTSD is that it might blind you to thinking that all of a young person's problems are some form of PTSD, and that you can kind of cram everything into that box. And I think you were very careful in the paper, Rachel, not to say that. You know, this is a paper about PTSD, but children or young people may also have other problems. You know, they may also have ADHD or fetal alcohol spectrum disorder or autism, and we need to be looking for all of those problems. But if we find PTSD, they can be treated for PTSD like anyone else.
Yeah, Helen, I think that you've really hit the nail on the head there. And again, what sometimes can get lost in when we're talking about young people in care is that there are often a lot of different comorbidities to manage, but the same is also true for almost all groups with PTSD. And they, you know, we have treatments for PTSD. We have really quite good treatments actually for PTSD. I don't think anyone's going to sit here and say trauma-focused cognitive behavior therapy will work 100% of the time for every person that you see. Of course, that's just not the reality of how things work. But we want to be going at least from a baseline where, very simply put, if a young person has PTSD, we're trying our best evidenced treatments with them. And not getting lost in the noise, basically. Not getting lost in the complexity of it, but just getting to the heart of it.
Well, I think that's a good point to just broaden the discussion out. We're going to put our slides that we've been referring to into the pack that goes with the package on the event on the website. But I thought that would be a good point to broaden the discussion. And Aishat, I'd like to bring you in to get your reflections on the direction we've been taking this discussion. How does that fit in with your views?
I'm so sorry, say that again.
Sorry, I was going to invite, I wanted to bring you in to give us your thoughts on what we're saying about the existing approaches, existing treatment approaches may already exist that we can offer people.
I think it's very important to highlight that, because a lot of the time when dealing with any sort of young person with trauma experience backgrounds, there's always a sort of stigma or stereotype associated with children in care, in particular of, oh, they're struggling, there's too much of what they've gone on, they don't know what's wrong. But who best knows of their experience than the person who has experienced it? And I think there needs to be an open mind given to all young people in terms of leading the conversations about their trauma, leading the conversations about their experiences, so professionals are able to really learn about that young person and what their experience means to them. I think, of course, it's great to highlight all the issues that there might be with the study in terms of representing certain people, young people, or backgrounds, ethnic backgrounds. However, I do feel like it's a great start in showing that there are already treatments available, that professionals have a guideline. And of course, I think it isn't a one size fits all. And I think what's also important is identifying what that experience means to that young person. A young person, for example, who's been through physical abuse, sexual abuse, may have had a lot of things going on, but it could be verbal abuse that they're holding on to, that they're having flashbacks about, nightmares about, things that really hit home to them. And those are things that a lot of the time you cannot guess, or you cannot see straight away from a young person. And I think from my own personal experience, avoidance was my biggest thing, in terms of pretending like it wasn't there and pretending like I just needed to get through the day, even if I got triggered. And it took me a long time to understand what triggers are, and to understand how to cope with triggers and how to ask for help and where to ask for help. And I think a lot of the time, young people don't even know what PTSD is. Young people are often fit into a background that always, it's just because they're in care. They've been moved around a lot. That's exactly what it is, instability. Of course, all these things have an impact. But again, imagine carrying all the baggage of your experience, as well as the instability, as well as the lack of support and trust in people. And I think what is also important that Rachel mentioned is the fact that young people in care with traumatic backgrounds struggle to know how to form positive relationships. And if you think about a young person who's moved from placement to placement, who's kind of used to the disappointment, they're not going to be very open to any professional that tries to speak to them about their experience, because they're not going to have that expectation of stability, of support. And I think a lot of the times professionals need to take a step back, as ironic as it sounds, to take a step back and allow that young person to get comfortable in their trauma, to get comfortable in their experience, so they can tell you where it is going, so the right treatment can be structured to the right young person.
Aisha, I'm so glad we got you involved. You're getting so much love in the chat, so read those comments. I wanted to ask you a kind of follow-on question from that, because you spoke about stigma, and obviously stigma is so important, the stigma of mental illness, the stigma of being in care, how do you think that affects young people's behaviour in terms of help seeking? And how do you think CAMHS needs to change so that young people from the care system, can overcome these barriers and get help?
Yeah, okay. I really don't mean this to offend anybody, but my own personal experience of CAMHS hasn't been great. In terms of when I first came into the care, I was offered CAMHS. No one explained to me what CAMHS was. No one explained to me where, my session or whatever would lead to, or what the purpose was. And initially when I went into the session, I found it quite patronizing. I found it to be, oh, darling, do you want to, it takes a lot for a young person, first of all, to get themselves to the point of seeking help, or accepting help. So in my mind, for me personally, I was like, okay, I'm coming to this meeting. I'm ready to talk about anything and everything. And I kind of got in there, and the first thing that was said to me was, oh, do you not want to be like the sun? Isn't it so bright? Isn't it so lovely, the weather today? And I was so confused. I was so confused. And I was kind of like, okay, but can we get to it now? I'm ready. And the further we went away from what I had prepared myself for, by the time we got into it, I didn't want to talk about it anymore. You know, I was kind of like, clearly I have built up myself for no reason. And I think a lot of the time the approach that psychologists or anyone working with young people take is wrong, in terms of, you know, pretending like the young person does not know their experience, pretending like they do not know the effects. They might not have a name for it, but I can tell you that they understand their experience. You know, so being open to letting that young person and being like, what do you want to talk about? Share the part of your experience that means the most to you. How did you feel when this happened? You know, of course, I cannot tell somebody how to do their job, but again, sort of looking at that young person, you can read notes, you can read reports on a young person, but how does that show you how they feel about their situation? How does that show you how they feel about their trauma? Do they even see it as trauma? Because a lot of young people don't even notice the parts of their experiences that have been traumatic. And I think that is what is important in terms of understanding the cause and effect of their symptoms. A lot of the times we read things, and children in care have already got that stereotype of being helpless and being very problematic. And if somebody leads with that foot, it kind of helps reinforce the trauma. It kind of helps reinforce the bad thoughts and the, you know, bad self motivations and stuff like that, because it doesn't encourage you to want to get help. It doesn't encourage you to trust another young person or trust another professional in your life into seeking help for what you yourself are struggling to deal with. So I think a lot of the times professionals need to be kind in their words and open and honest. You know, I think children in care are often underestimated. I think that's the best way to put it. You know, as much as we can say that children in care are expected independence without being taught independence, but the one thing they have been independent in is themselves. They have had to deal with a lot of things themselves. So when it comes to any conversation about their individual experience, have the confidence in them to be able to work on it, to be able to talk about it. Because if you don't feel that positivity from the person that supports you, you will not feel positive about your way of helping yourself or the coping strategies being offered to you.
Thank you. It's really powerful to hear you speak so openly. You're getting lots of applause. Well done. And yeah, I mean, lots for us to reflect on, you know, as individuals, as therapists, as people who work in the system, as researchers, people who have an impact on how the system, you know, is organised. What do you think, Rachel, listening to Aisha there, what do you think needs to change so that the services that we offer to young people from care, you know, are more, you know, more useful for people and more something that they can actually engage with?
I think it would help if Aisha was our Prime Minister, to be honest. That would probably be a good start. But also I would say that I know, you know, we work with a lot of young people in the care system and young adults that have been through the care system, and we hear this again and again and again, and we need to be listening to this. You know, we need to really be listening to these voices. And that, you know, that's partly how we managed to get this research done, is by saying, you know, young people can actually be asked about their mental health. They do have capacity to talk about their mental health, and they actually have capacity to talk about very difficult things. And sometimes they want to be able to do that. And so to me, really the take-home message and something we find in our research a lot is that young people in care have been sent to CAMHS and had a negative experience and then will never engage with mental health services again. And that is an absolute shame. And I don't, you know, I work with CAMHS clinicians. Lots of my close friends are CAMHS clinicians, so that's not really actually even about bagging the individual clinicians. There are whole systems that need to be looked at here in terms of the capacity and the training and the supervision and support that is available. But I guess what we really want to get across here in the paper, and bringing it back to that conversation, is if you are working with young people in care, and you suspect they might have PTSD, or even actually don't suspect it, you can do a screening tool with them. You can ask them you can ask them about that. A few people in the chat have asked about a screening tool, and if you work with young people in and where it's appropriate to do screening tools, there's one called the CRIES-8 that is freely available online. It's a core measure in CAMHS, and I can put a link to that. But if a young person in care has PTSD, they should be getting our best evidence-based treatments. And this is specifically about PTSD, but that is true for any mental health diagnosis, that young people in care deserve our best evidence-based treatments. We don't need to be making up different treatments. We don't need to be putting our presumptions on them. We have some really well-researched mental health treatments, and young people in care should be getting access to them as much as any young people are. Helen, did you want to add anything onto that?
I just said here in the chat. I also think, though, there is still a massive evidence gap. So in addition to evidence-based treatments, Aisha, for example, was talking about the relationship difficulties. We've got a trial just starting about DDP. DDP's used. We need to have trials. So it's both and, but absolutely good assessment, good screening, use of evidence-based treatments for what we find when we can, and more research.
Yeah, and that also raises the point of, what I'm not here saying you need to now go, if you're a clinician listening, I'm not saying you need to go away now and give all of your care experienced young people trauma-focused cognitive behaviour therapy. What I think we're trying to get across is, if PTSD is the issue, that is the treatment they should be getting. They might have other primary issues that need addressing, but to break it all down, if PTSD is the issue, that's what they should be receiving.
Can I say one other thing, which is this thing about avoidance? Because half of the young people, Rachel, that the social workers consented decided not to take part. And back to that toothache thing, I mean, let's face it, if you've got horrible memories flying at you, you're maybe less likely to want to do research about those. And I just think for clinicians, we need to remember that it's really difficult for young people with PTSD to seek and accept treatment. There was a good comment in the chat about that. The onus is on us to be open to that. And if it doesn't work at that time, to open again. And I'm not wanting to criticise my CAMHS colleagues, because actually our services are not set up like that.
Yeah,
so the message needs to go to, before we can get Aisha's Prime Minister, that message to the current Prime Minister. Yeah,
exactly. Yeah, I just think that's exactly right. We just need to find ways to do better, but we're all managing in very difficult systems. But the fact that avoidance is so core to PTSD, and again, not just in care experienced young people, in anyone with PTSD, that is a core symptom. We do research with young people living in South Africa. We find exactly the same thing. But if you say, and I always give this example from some qualitative work we did, where we always say to young people, if you had a friend that was going through what you were going through, what advice would you give them if they were really struggling? And this was some work with care experienced young people again. And this young person said to me, oh, I'd tell them they have to go and talk to someone, because you can't keep it all inside. You've got to go and talk to someone and work out how to get help. And I said, is that what you did? And she said to me, no, I would never do that. And that's kind of the crux of it, is that we all know that if we're struggling, it's helpful to talk to people, but actually making that happen is a different step. And if you've got PTSD, it's an incredibly difficult step. So as Aisha said, if you manage to get to a service, and if you manage to get to a point in yourself where you think, I'm ready to engage in this, we need to be there to make sure we're approaching that in the best way possible.
What about priorities for answering other questions? What are the kind of research priorities, do you think? Helen, do you want to answer that first?
It took us 10 years to get funding for the trial for DDP. And one of the reasons was that I don't think anyone could believe how little we know. So I think there's a big research priority for younger children, under 12. There's such a huge evidence gap. For me, I think you need pragmatic, clinically focused work of the kind that Rachel's done, and we have to have young people working with us. I mean, it would be ridiculous to try and do that clinically focused work without people like Aisha, because we need to understand what it means in practice and what it's like on a day-to-day basis.
So is it more about the type of research that we do?
It's the type. I think it's the type. Right. Pragmatic trials. We need pragmatic randomized controlled trials, and we need good follow-up studies, just like Rachel's done. I would think, using sensible, holistic measures, and they're not going to be cheap.
And Rachel, in your work, is it that there's no funding at all for research, or is it that it's being funded in adults and not in young people?
It's
oh, sorry,
adults.
Helen, you go.
No, I was just going to say I was just going to say mainly adults, but anyway, go for it, Rachel.
Yeah, I mean, well, there's not enough funding for any mental health research, let's face it. That I think we all think that's bottom line. But as Helen said, the research we have, we talk about the inequality and the inequity that young people in care face, and that's also absolutely true for the research quality that services have, that young people have to draw on to address their needs. So there's so much work that could be done. Our follow-on from this work, actually, we've been really lucky to get some funding to do trials to look at how we can start treating PTSD in this group, and partly that's looking at kind of lower intensity options, because we know there's so many young people that need support, and CAMHS just doesn't have capacity to pick that all up. But we're also soon looking at how we can implement trauma-focused cognitive behaviour therapy within services. So let's look at why we've got this huge gap between research and practice. What is going on? And part of that will be near impossible to address, but I refuse to think all of it can't be addressed. There's got to be something we can do to move the field forward. But I think the other thing that we need funders to realise is that there's just so little research on young people in care that we have to make sensible and pragmatic decisions. It's not going to look the same as research on big populations of children, and that, I'm sure Helen and I are both in academia, so I'm sure we've written that back to about 20 reviews in the last 3 years or something.
So let's bring it together. I'm sorry, we're out of time. This has flown by so quickly. We need to wind it up, I'm afraid, but it's just been brilliant listening to you all, and we've said a lot of stuff here that needs to be actioned. So we'll summarize that, and we're going to share the video and the slides and all that kind of stuff on the ACAM website after the meeting today. Just a couple of things we want from you before you go, though. The first is to find out whether this paper has changed your perspective on this issue. So it's a quick poll that's popping up on your screen here. If it has, and you strongly agree, then that's a 10. If it hasn't changed your perspective at all, then that's a 1. So tell us about your view of this paper and this research and this whole conversation that we've had tonight. And Rachel will stick this in her next grant application, evidence of impact. Well, depending on the result, maybe she won't, I don't know, we'll have to see. How are we getting on, Matt?
Yep, people are flooding in with their responses, so I can just see, oh, one person hasn't done it yet. Oh, no, they have, well done.
Wow. Okay, well, that's pretty impressive. So that looks like 20, 40, 60% say 7 or over.
I mean, I feel like as a researcher, I have to point out there might be some limitations to your survey method, having me sitting on the phone here, Andre.
Yeah, of course, it's totally new.
Thank you, everyone, for being kind.
Like most ref impact evidence, it's based on a flawed method and sample. And one final thing we'd like to ask you is whether you've enjoyed tonight and whether you'd recommend these sorts of events to your colleagues and to your friends. 10 is yes, a lot, and 1 is not a lot. And while you're filling that in, I just want to say thanks to everyone who's joined us this evening, especially to Rachel and to Helen and to Aisha for just sharing and being part of the conversation and being so open and honest and thoughtful. to Douglas and Steph and Matt, who as always have been brilliant, helping make this happen. We've got 2 more campfires coming up in the diary. We've got one on the April the 26th on self-harm, support tools for school staff, and another one on the 25th of May on ADHD and medication for young people with autism. Those are both bookable on the ACAM website, so have a look if you'd like to come along. And oh, that's a nice result. So thanks very much for such positive feedback. Do tweet at CAMHS Campfire if you've got any other thoughts on what we should be doing with these sessions. Thanks very much for joining us, everybody, and we'll see you next time.